All right, we are now officially recording. This Zoom is to review requirements for CP2. So CP2 is the assignment that you would have done during your med-surg rotation. Basically, it revolves around care planning and evidence-based practice. So for CP2, if you kind of break it down, there are 3 separate sections. And the first one would be the narrative assessment. So obviously you are not physically at clinical able to do a physical assessment on your patients. So CP2 is going to be completed on the case study, the ATI real life clinical reasoning scenarios, the COPD case, okay, Hector Gomez. And I don't have my calendar in front of me, but I want to say he is assigned for April 8th. Which means your CP, parts 2 and 3 of your CP would be due the following week. So that would be April 15th. But the first part of this, as I was talking about, is the narrative. So for the narrative, what you are going to do is complete the case based on, the instructions. You're going to do the case. The narrative piece that you're going to do, your narrative assessment, is going to be based on the information from your report. You'll get to see in the video, the ER nurse is giving the floor nurse report, and also based on the first interaction video that the nurse has with the patient. Now, obviously it's a COPD case, so most of that is going to be respiratory. So in order for you to do the entire narrative assessment, within the documents that are on Plato, there is a section on there that talks about additional assessment data. So you will want to incorporate that information into your narrative. What I would recommend in doing that is, you've all been doing narratives all semester, so hopefully you got some good feedback from your instructor. There are also the narrative guidelines document that is on Plato. So you want to take a look at that. The rubric is also there as well. So I grade all the assignments the same way. I have your assignment open on one screen and I have the rubric open on the other screen. So that's exactly how you are being evaluated. Use the guidelines for assessment documentation to help you. Common things that students have missed or lost points for, I should say. Make sure you're using abbreviations rather than writing out non-productive cough. You can go NPC. B/L for bilateral. So making sure you're using abbreviations, making sure you're using appropriate terminology. So ecchymosis instead of bruising, edema instead of swelling. Make sure you are specific if you're talking about a location. So for example, if you're going to say that the patient has wheezes, where are they? Are they posterior? Are they anterior? Are they left? Are they right? Are they bilateral? Are they upper? Are they lower? Are they throughout? So anytime you're talking about something with a location, breath sounds, edema, some sort of skin issue, whether it's bruising, a wound, you want to make sure you're using those terminologies and the anatomical terms to describe the location. The other thing that students lose points on is related to extra words, okay? I'm always harping on you for proper grammar and spelling, but the narrative assessment is the one area where you do have to properly spell. You can't misspell, but we want to use as few words as possible. There's a lot of commas, there's a lot of semicolons. So if I'm talking about cardiovascular, for example, 137/82, comma, manual, comma, right upper arm, comma, semifowlers, semicolon, apical rate 82, regular, comma, S1, S2 noted, comma, no murmurs, semicolon. Then I start talking about peripheral pulses. So you're not adding extras, is, ands, ofs, was, all of that can go. Okay, because the reality is when you're doing a narrative, it takes longer to write than if you're just clicking on the EHR. So you don't have time for that extra stuff. You don't need to say patient because it was understood. If it's something the patient said, just simply put it in quotes. Okay, you don't need to say patient stated and then put it in quotes, because when you put it in quotes, that's understood. So that's the narrative piece. Now the narrative is going to be due that day. Okay, the narrative is due that day or that Thursday, I want to say. Check on Plato, because the students who already completed CP2, when they submitted their narrative, it was at the end of their clinical day. Okay, that's when they submitted it. So just, you know, to be equitable and fair, that is going to be due that week. The second and third parts of CP2, the pathophys statement and the nursing care plan, those are the ones that are due the following week. I want to say April 15th, 16th, somewhere in there. Just make sure you're checking on Plato for the exact date. And those pieces get done on the template, on the CP2 template. So part 2, which is where the pathophys statement is, looks very much like your clinical prep. Literally, it's the same pathophys statement, except there is an extra section in each area that talks about client specifics. Now, again, you are doing CP2 on the real life clinical reasoning scenario COPD patient. So this is where you will put in specific information to that patient. Okay, anything from their chart, the EHR chart that is on the ATI, anything from the additional clinical data, additional assessment data, the MAR that's in the EHR, all of that patient-specific stuff can be worked into there. So for example, you're used to doing pathophys statements. So you're used to the disease process at the cellular level, and you talk about etiology and risk factors. There's an extra section on the template that says client-specific risk factors. So that's where you would, you know, this client had these specific risk factors, blah, blah, blah. Down in clinical manifestations, you talk about the general signs and symptoms. Your client-specific would be, this client presented with da, 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 da. Same thing for the lab and diagnostic test. You would use the information off of the EHR. What did the lab show? What did the chest x-ray show? And you would include that information. Down in the treatment section, the medical surgical treatment section, you're going to do your regular stuff, but there's a section that talks about client-specific treatment. That's where you're going to use the information from the EHR from that video case study. So what antibiotic was he on, what breathing treatments was he on, what kind of oxygen was he on, all of the patient-specific stuff. You're going to get that from the actual EHR within the video case study. And then that last piece is the teaching statement, and that's no different. The only thing I would ask is when you're talking about your treatment plan includes, try to incorporate the actual stuff we were doing for Mr. Gomez within the video case study. Okay, as opposed to just taking, you know, a generic, this is how we would treat it. So that's part 2. It really is not a whole lot different than what you've been doing every single week with your patho statements. Just make sure you're following the rubric. You should have been getting feedback about your patho statements. I know I did the supplemental instruction on patho statements prior to spring break. So if you go back into the class Plato, the section under supplemental instruction, there should be some resources there as well. But I tried to organize the clinical Plato to make things a little bit easier to navigate with all this changing stuff. I hit a lot of things that we're not using anymore, that we didn't need anymore. So when you go inside that week or inside CP2, there should be a section that says student resources. So all the stuff related to CP2 that can help you, previous capture videos on nursing process, on pathophys, narratives, all that's in there. The APA handout is there, just to kind of have it in all one area for you to be able to easily find. So that's part 2. Part 3 is essentially a nursing care plan. So for those of you that came from Mrs. Brenchley's class last semester, it's pretty much like your CP3, okay, from last semester. If you came from Mrs. Havilar, it's pretty much like her, her clinical packet. Basically, it is a nursing care plan. So based on the assessment data from your narrative and based on your experience within the clinical, the video case study, you're going to identify the client's priority nursing diagnosis. You already know the topic, it's COPD, so let that kind of guide you a little bit. but you're going to find select the priority diagnosis, your NANDA. You're going to note the related to, so what is the cause of the problem, and what is the as evidenced by. Definitely go back and take a look at the student resources related to nursing process, because that will kind of help you with that. But that's no different than you've been doing every week on Med-Surg on the backside of your clinical shift worksheet. You've been doing it every week. Now, for this CP, you are going to have to write a goal. That is not something you do every single week, okay? But go back and look at the resources. The goal is what you want your patient to achieve. In this case, he's an inpatient, so you might say by discharge, okay? Remember, goals have to be specific, measurable, and have a time frame. They also need to relate directly to the problem that you chose. So for example, not related to this patient, but any other patient, if your patient's priority diagnosis was acute pain, your goal should demonstrate the resolution or management of that pain. You know, client will be pain-free by the time they, you know, leave the hospital. That's not realistic for a post-op patient. Or client will verbalize adequate pain management with a score below 3 out of 10 on the numeric scale using only oral medications by the time they are discharged. That's very specific, it's very measurable, it's realistic, and it has a time frame. So as you're formulating your goal, you need to make sure you're making it hit those criteria. Your interventions, okay, that's kind of the next piece, your interventions. You need to make them specific. I want you to think about the dumbest person that you know, somebody that you would never want taking care of you, but they can read and follow directions, and they will follow your directions to the T, okay? They can't think their way out of a wet paper bag, but they will follow your directions to a T. And that's how you want to write your interventions. So rather than saying administer pain medication, what pain medication is it? What's the dose? What's the route? What's the frequency? Under what circumstances would it be given? Okay, so very specific. Same thing, you know, focused respiratory assessment, focused pain assessment. Okay, well, who is doing it? Who can do the assessment? So think about scope of practice. Is it something the RN can do? Okay, is it something the RN or LPN can do? Is it something the RN LPN aide can do? If it's related to a breathing treatment, is it respiratory therapy doing it? If it's, you know, related to positioning or therapeutic exercises, is it physical therapy? But who's doing it and what are the specifics? Okay, how often is it being done? How long can it be done? You know, we always think about range of motion exercises. Okay, well, what joints are we doing those range of motion exercises on? Okay, how often are we doing them? How many repetitions are we doing? So you want to be very specific with your interventions, okay? Each intervention needs to be supported by a faculty level rationale, okay? And everybody has done CP1. Everybody has gotten feedback on rationale related to, are they patient level or are they faculty level? These are faculty level, okay? They need to be cited. Your intervention itself does not get cited, okay? It is the rationale that gets cited because that is evidence-based practice. Now, that being said, I'm going to jump back up to interventions here for a minute because I forgot to mention something. With your interventions, making them specific, you're like, well, how do I know what med? How do I know? Look at your patient's EHR. Inside the scenario, inside the video case study, you have the EHR. It will have the medications. It will have provider orders. It will have diagnostic test results. So you're going to individualize these to Mr. Gomez based on what is in that chart. The same way you would have done at clinical. If you were doing this care plan on the patient you last took care of at clinical, when you talk about medicating them for pain, what exactly did they have ordered? What was prescribed for them? What were we giving? If they were getting an antibiotic, what antibiotic was being given? How often? If we were giving a breathing treatment, what were they getting? How often were they getting it? Who was doing it? Was it the RN? Was it respiratory therapy? Okay, so that's where you want to get your details for those interventions. back to the rationale. Again, faculty level, they need to be evidence-based. So your best resources for that are likely going to be your fundamentals text, your Hinkle and Cheever. You can use Lippincott Advisor. A lot of you have a care planning book, or you use the care planning resources on Lippincott Advisor. Remember, they will give you interventions. They will even give you goals, but remember, they have not seen Mr. Gomez. Okay, so those are very general. You need to tailor them to Mr. Gomez. Okay, all right, let me address the questions on the side before I keep going. Just double checking 2 rationales. No, you just need faculty level rationale for this, because this is not related to patient teaching. Now, if you do an intervention related to patient teaching, and I encourage you to at least have one, if you're teaching the patient about something, you would want to explain to them why. Okay, so that's where you might get a patient level rationale, but the rationale that are required for each intervention are going to be the faculty level rationale. Yes, the narrative must be handwritten. So that one, you're going to print off the template, you're going to handwrite it, either scan it, take a picture of it with Genius Scan, and that's what gets uploaded for the narrative. So we only talk about the interventions in the EHR orders, or do we think about the interventions ourselves? Great question. You can think about the interventions yourselves. Just because it's not in the EHR doesn't mean it's not appropriate. However, in real life, if I wouldn't have an order for it, what would I do as the nurse? I'm going to collaborate with the provider to obtain an order for that. Okay, so yeah, it doesn't have to be in there, but if it's something you're like, you know what, we should be doing this for this patient for this reason, you can absolutely do that. And remember, not all interventions require a physician order. I don't need a physician to tell me to turn my immobile patient every 2 hours. Okay, I do need a physician's order if I'm like, you know what, this patient hasn't pooped in 5 days and it might be a good idea to give a Miralax. I can collaborate with the provider to get that order. Okay, and then once I have that order, I can then implement it. But some things are collaboration. There's some things you're going to be able to do independently. Okay. I think we're up to date on the questions. All right, so then moving on, I'm going to hit evaluation, and then I'm going to go back to the psychosocial piece. So the evaluation part, and this tends to be, I think, the most odd for students because you need to write an evaluation statement. Now, I know that, you know, you're going to evaluate this patient. In real life, you would be evaluating them at the same time you're writing the plan. Realistically, in real life, we would write the plan and we would evaluate at whatever the time frame is that you put in your goal. For this assignment, we don't have the option to do that. So what you're going to do, you write your goal, and then you look at it at the last point of when you saw the patient. So at the end of the case study, did your patient meet the goal or not? Yes or no? Okay, there's no half and half. It's either goal met or goal not met. Okay. If the goal's met, great. You say goal met, and then you repeat your goal, okay? Because they met it, we're good. If it's goal not met, which a lot of times it is, goal not met, then you need to provide a summary of where your patient is. So for example, let's say a goal for activity intolerance would be that the patient would be able to ambulate 50 feet without becoming short of breath within 2 days, okay? And 2 days passes and they can't go 50 feet without getting short of breath, but they can go 35. If I was doing that, it would be goal not met, client only able to ambulate 35 feet before becoming short of breath. Then I want to talk about, okay, what am I going to do to modify the plan of care? Maybe I'm just going to continue the current interventions and reevaluate in another day. That's okay. I just need to say that. Maybe I'm going to continue the current plan of care, adding an additional intervention. Continue current plan of care with the exception of adding new antibiotic of Rocephin 1 gram IV piggyback Q24 to better treat the underlying cause. Reevaluate in 2 days. Okay, but if your goal's not met, you need to state that. You need to give a summary of where your patient is and their progression towards the goal. And you need to address what you're going to be doing about it with the plan of care and when it's going to be reevaluated. going back, I'm just trying to think on the template. It's between your goals and your interventions. There's a box that talks about psychosocial compatibility. So it says something to the effect of describe how your interventions plan of care is compatible with each. And it talks about the client's culture, ethnicity, spirituality, religion, so on and so forth, all of your psychosocial factors. So there's some examples of this on Play-Doh for you to kind of take a look at. But this is where you want to consider those psychosocial factors, identify what they are, first of all, and give me a little synopsis on the patient, but then also address how they would work into your plan of care. So, for example, a couple semesters ago, my students were taking care of a patient down at Jersey Shore who came in with a possible stroke, rule out CVA, TIA. Turned out not to be. We were thinking maybe it was a TIA. So our focus at the time of discharge was more knowledge deficit. We were trying to teach her about reducing her risk factors for a future TIA. And one of those things was talking about exercise. So we had an intervention teaching her about increasing her activity level, you know, taking a 30-minute walk at least once a day. And this particular patient had a dog at home, okay? And that was going to be a motivating factor for her because then she's able to take the dog out walking with her. So by addressing that and including that in that little section where they were talking about psychosocial factors, that showed consideration and inclusion of that information. It could be that, you know, the patient's family member, they live with their spouse, they have a very caring relationship and the spouse picks up their medication at the pharmacy. Okay, and that's a way you're incorporating family dynamics in there. So I would recommend taking a look at the examples that are on there. You definitely want to make sure you're addressing that. Again, for the psychosocial factors, you're going to be using the psychosocial factors that apply specifically to Mr. Gomez from the video case study. Okay. Okay, let me come over here. Are we going to get points taken off if you don't think our interventions are necessary related to the orders? No, I'm looking for interventions that are appropriate, that are related to the problem. So I want to make sure I'm understanding you here. So let's say the problem is acute pain, okay? You want your interventions to focus on the problem that you identified. So let's say this is a post-op patient, they're having an issue with acute pain. And yes, it's true in their diet, I do want to increase protein in their diet and zinc to help with wound healing. So in real life, while that's an appropriate intervention, it doesn't relate directly to the problem of focus that you selected, the acute pain. So I would evaluate it. I would evaluate that intervention to see, you know, is it specific, you know, does it have all the, you know, details in it? But I would mark on there that, you know, while it's appropriate for the plan of care, it doesn't relate directly to the problem of focus. So I think that might have been what you meant with your question. I'm not quite sure. If it's not, please let me know so I can clarify more. Couple other things with this, you do want to make sure that you run spell check on this. You want to make sure that you grammar check. Honestly, have somebody else read your paper or you read your template. If you don't have anybody else to read your template, you read it yourself, but read it out loud. Because if you're reading it silently, and I know this happens to me all the time, I got typos and stuff, and if I'm reading it silently, my brain will actually correct the typo for me. So, you know, have somebody else read it or you read it out loud, because if you're reading it out loud, you're going to pick up something that doesn't make sense, or you're more likely to. So I encourage you to do that. I would also encourage you, you know, to have somebody look at your paper along with the grading rubric. You know, have somebody else mock grade your paper. That's always helpful to kind of pick up any type of pitfalls. Usually with the patho statement, most students are scoring 90s or 100s. Occasionally we'll get an 80. Usually if it's that, it's because they left out key details. Now, not that every single thing needs to be in there, but for example, let's say you were doing a patho statement on type 2 diabetes. If you, under medical treatments, just mentioned there are oral anti-diabetics and they can work to lower the blood sugar, that's not going to be enough. I don't expect you to go into every single classification, but the 5 ways that we talked about in the previous Zoom on how those oral anti-diabetic meds work to lower blood sugar, that's a key point. That should be included. With pneumonia, when you're talking about etiology and classifications, you know, I'm expecting to see, you know, at least a mention of community acquired pneumonia, you know, ventilator associated pneumonia, hospital healthcare associated pneumonia, aspiration pneumonia. You know, so there's some key things in there. If it's a chest pain, a myocardial infarction under labs, I better see troponins in there. I better see an EKG in there. So when I look at those pathophys statements, I'm looking for things that are very much associated with that disease process. I'm not necessarily looking for the most obscure thing in the world. I mean, if they're coming in with a respiratory issue, a chest x-ray better be there. You know, it got to be there. Can you go over what you want for the disease process at the cellular level? Sure. So with the disease process at the cellular level, I want you to tell me what is actually happening. For this guy, it's COPD. So what is actually happening down there? So when COPD happens, how does that change the alveoli? Okay. And because of those changes in the alveoli, how does that affect gas exchange? With COPD, you have increased secretions. Why? Okay, why do those increased secretions occur? And how does that impact airflow? How does that impact oxygenation? Okay, does that help? I'm thinking maybe, possibly. If you're talking about inflammation, like pneumonia, stuff like that, and you talk about, you know, where the alveoli fill with fluid. Okay, well, why do they fill with fluid? It's exudate. Okay, how did that exudate get there? You know, when the inflammatory process happens and those white blood cells go there, what do they do? How do they result in exudate? So I think I might have hit that. I'm hoping I hit that. What other questions do you guys have? I'll just give you a couple minutes here if you have some questions on the side. I'm happy to answer, you know, whatever questions you have. I know obviously this isn't ideal. I would have much preferred you do CP2 on a physical patient that you were taking care of, but it is what it is, you know. So I'm assuming that's a faculty level rationale. What's a faculty level rationale? I don't know what you're talking about here. Are you talking about the example that I gave, like with the exudate? The disease process. Well, yeah, that's not necessarily what I would, the rationale are specific to the intervention. So you're explaining why are you doing that intervention and how specifically does that intervention work to correct the problem, okay? So for example, let's go with something basic. Let's say this is a care plan for risk for infection. We'll keep it really simple. And one of your interventions is performing hand hygiene before touching the patient. So a patient level rationale would be hand hygiene will help prevent infection. Okay, that would be something you would say to the patient. If you were doing a faculty level rationale, you would talk about hand hygiene, the physical washing of the hands, the friction is actually going to physically remove the bacteria and pathogens that are on the hands, and rinsing that off removes them from the hands, thereby reducing the risk of spread of microbes through direct touch. So that would be what we would consider like a faculty level rationale. For like constipation, okay? If you tell a patient, I want you to increase the amount of fiber in your diet, you want 35 grams, I want you to increase your fluid intake to about 2 liters a day, and that will help prevent constipation. That would be for a patient. If you're doing a faculty level rationale, okay, how does that fiber help prevent constipation, okay? It increases bulk in the stool. That bulk is going to touch the bowel walls. It's going to stimulate peristalsis and push it through to be evacuated. The fluids that you take in are going to help keep the feces and the stool soft, so it's easier to pass. And that's why you do fluids with fiber, to help stimulate the peristalsis for evacuation. So, does that make sense? Disease process at the cellular level presented. Okay, disease process at the cellular level. You don't need to present it in faculty level rationale format. I just want you to make sure you're explaining the detail needed to get to the cellular level. So I think I covered that. Other questions at all? It's a big assignment, and it's an important assignment because it really relates to items that are specifically on your weekly clinical evaluation. So when we talk about the narrative piece, that relates directly to the communication behaviors, particularly to charting. The pathophysiology relates to evidence-based practice. The rationale in the care plan relate back to evidence-based practice. The interventions, the goal, the evaluation, the nursing problem, the diagnosis that you pick, that all relates back to nursing process itself. The teaching statement, part of the pathophys statement, relates to teaching and learning. That psychosocial box in the intervention section relates back to consumer-centered care. So this assignment, it's designed this way because it really hits at almost everything in your weekly clinical evaluation. And quite frankly, it even hits professional behaviors because it talks about submitting it on time. So it really is a culminating assignment. And that's why, you know, when State Board of Nursing can come in, they can pull any one of your files and they can say to me, okay, show me how so-and-so met the outcomes for NUR 188. And I can show that in the weekly clinical evaluation, and I can show that in the CP assignments. And that's actually why we have that stipulation that if there's a section of the CP assignment that is below 75, that you have to revise that till it gets above a 75. It doesn't change the original grade, but that's why we have that there, because then I can say, yes, this student has met those clinical behaviors related to this course outcome. Okay, let me see. The patho is in layman's terms. No, the teaching statement portion of the patho would be in layman's terms. Now, that being said, you know, this isn't my first rodeo. I can tell if your patho came from the textbook directly. Okay, I can tell. So if you're using a technical term, use the term, but then define it in parentheses. So I know that you know what it means, okay? And that's what I like to do at clinical, is I like to talk to students about their pathophys, you know, because I can tell, you know, it's when it, like the one time many years ago, I was passing meds with a student and we were talking about meds, and you know, she said that, you know, Lasix inhibits reabsorption of sodium, potassium, and chloride at the distal end of the loop of Henle of the nephron. Okay, I can copy that out of a book too, but what does it mean? What does it mean? How does that work in your patient? Okay, so if you're using a technical term, do make sure you define it. But, you know, if you were doing a patho statement on diabetes and I didn't see the words polyuria, polydipsia, and polyphagia, you know, those are key pieces that should be there. Let's see, do you want us to cover all race, ethnicity, religion, etc. in the psychosocial portion of CP2? Yes, you need to do that, because if you look at the grading rubric, it actually specifies all of them. Now, I'm pretty sure I went through the video case study. I think everything is addressed. If for some reason I missed something, like, you know, let's just say it didn't address his religion. I'm pretty sure it did. But let's just say it didn't. Just put a little statement in that box that said, regarding religion, this was not addressed in the video case study. Okay, boom. Then you have addressed it by telling me it wasn't addressed in there. Okay. But you do want to look at all of those factors, because that is consumer-centered care. That really is tailoring the nursing care that you give to your specific patient. Okay, other questions? I think this was productive. I think this was a good session. Are we able to send you a rough draft? No, you're not able to send me a rough draft. And the reason I do that is because there are 35 of you and I just physically cannot review a rough draft on everybody. And if I do it for one, I would have to do it for all. So for fairness, I cannot. Now, that doesn't mean that you can't discuss it with me. I can't look at your draft, but you could send me an email and say, hey, here's kind of what I'm thinking, and I can let you know if you're going on the right path. We could even set up another Zoom appointment like this and do like a group thing, because that's actually what I was planning to do, just like I did with the first group that had done CP2 on their actual clinical patients. No, I can't look at your narrative ahead of time either. That's something, if you want to have a peer look at it, that's fine. But I cannot preview assignments because that would create an inequity amongst students. And I'm a lot of things, but one thing I am is balanced and fair. I would encourage you to use the resources that are on Plato. Like for example, the narratives, that narrative documentation guidelines form to kind of help you. I would look at your previous narratives, go through them with that guidelines form, go through a previous narrative with the rubric and grade yourself and see, how would you have fared if that had been your narrative that was graded, and what would you need to fix? I mean, that would probably be the best thing. Should we go off your examples you have posted for the narrative? I would actually go off both. Obviously, I am the one that is grading this. So, I am going to grade it based upon, I'm going to grade it based upon the rubric. So there may have been things that your clinical instructor might not have picked up that I might pick up. So I would look at my examples, but I would also look at the feedback that your clinical faculty have given you. Because they might have picked up on something that I didn't. So I think both are very beneficial, but I would strongly encourage you to use the resources that are on Plato. They're there for your benefit. I provide them for you. I can't make you use them, but I can provide them for you. Let's see. I wasn't sure if the ones who have already submitted their narrative. No, their narratives, the ones that did this assignment previously, they had to upload their narrative immediately after clinical that night. So they did not have feedback from their clinical instructors before they uploaded it and submitted it to me. And that's why I need to do the same thing with you guys, just to have a balanced playing field with that. Other questions? Just give you a minute here if you have anything else. Otherwise, I am going to, when we end this meeting, it was recorded. It has to do some sort of conversion, and then I'll make sure it gets posted. Yes, narrative is handwritten. Let's see here. Can you give an example of how to write respiratory depth? I would just say if it was shallow or even, shallow, even, deep. That's probably how I would do that. Depth is more of an issue with respiratory when the patient's there with a respiratory problem. So is it very shallow breathing? Is it very deep breathing, fast breathing, like Kussmaul's respirations like we would see with a DKA patient? With your respiratory patients, when you talk about shortness of breath, shortness of air, it's always important to note, is that at rest with activity, or is it with both? Okay, because typically if they're having shortness of air at rest, they're going to have shortness of air with activity or dyspnea on exertion. All right, so what I was saying before, this recording, I will get this up on Plato. I think, is everybody kind of into doing like a Zoom session after you do this assignment, just so we can kind of talk through some things? Similar to what I did with the previous students, because that would be fair and equitable. I did that with the first group. I think it was the day of our exam, after our exam, the last one. But just kind of talking through, you know, what were you thinking about with regards to interventions and that, you know, because I did it with the other group and I'm happy to do it with you guys because that's what's fair. You know, I like to be fair. So let's plan that. So this is assigned the 8th. So we'll plan for the 10th. It'll be a class day. I can put it out there. I am going to have a regular Zoom that day for class. So this would be a separate Zoom. We can probably do it right afterwards, you know, and again, I would record it and, you know, and put it up there for people to be able to access. You know, my goal is to try to make this, you know, as user friendly for you as possible. I know we're all kind of dealing with brand new things here. You know, learning how to, you know, use different technology and kind of being isolated from each other. So, you know, I'm happy to do that. Anything I can do to help facilitate your learning, I definitely want to do. So let's plan to do that. We'll say April 10th, the class Zoom will start at 12:30, and then we'll just pencil this one in for right after. I didn't really have a set time frame. I wasn't quite sure how our previous Zoom was going to go. It actually went a little longer than I anticipated, but I'm perfectly fine with that. So maybe if we just say this one for CP2, let's just plan for 2 o'clock on April 10th. And if, you know, if we finish the other one early, we can always kind of bump that up. We'll play it by ear. But all right, any last minute questions for the good of the order? No? Okay, I will be available via email. I know tomorrow is the alternate clinical experiences, so I'm going to get in touch with Mrs. Morrison because she's the one that kind of worked on all the same day stuff. So we'll make sure we're available if you have questions, concerns, and we'll kind of work through this. So, all right, if no one has anything else, I will see you sometime. I will be putting some announcements up on Play-Doh, so just make sure you're checking your email and checking Play-Doh, okay? At least on a daily basis. You got to give me a little bit every day. I'm going to be harping on you because you need to stay up to date at least a little bit every day. It's even more challenging because we're in the distance learning format right now, but it's doable and we're going to do it together. And I might be the nagging mom, but that's okay. I'm going to do it. We're going to get you through this. So, all right, enjoy the rest of your day.